right. Thank you. I'm very honored to be here, very pleased to be here. Thank you, Marcelo, for inviting me. Thank you for the council. Thank you, Ram and Marcelo, for organizing such an interdisciplinary, transdisciplinary conference. I've never been to one where it's not an echo chamber, where we're not all talking to the same types of people. Now we can all go back, just like the mayors and the governors, to our respective geographies, but our intellectual geographies, and take back what we're learning from the various other disciplines. So I think it's really great. Thank you all for being here and being the hardcore intellectuals and hardcore believers. I have unfortunately the honor of being the last speaker, which I'll take as a big honor of being the final keynote, I'll call it. That's what I'll tell my mother. Okay. So just by way of introduction, I'm a bit of an oddball. I'm a scientist by training. I'm a molecular biologist, cell biologist, RNA biologist, but I'm also an entrepreneur and an inventor of bioplatforms. I've founded over a dozen companies in the bioplatform space, in the therapeutic space. I come from a firm called Flagship Pioneering, where we create breakthroughs in human health and sustainability, and we build bioplatform companies. But you'll say, well, what does that mean? And at another time, I would love to come back to talk to you about our sustainability efforts. We use biotechnology and chemistry to improve agriculture, livestock, and work on ecology per se, but we also work primarily on human health. But our claim to fame, our biggest claim to fame, is that we were the founders of Moderna. We did the fundamental science that led to the creation of the company. We're still involved with the company, and we take great pride in that. And that's going to be part of the theme of my talk. I don't represent Moderna, but I will talk about what it represents. We've founded over 100 companies since 2000. We are 150 scientists doing this work in one location in Cambridge, Boston. We've filed 400 plus patents, and we actually have 400 issued patents to our name. So we actually invent the technology and create the technology, and we have a lot of capital at our disposal, like a venture capital firm, but we have capital at our disposal to create the companies ourselves. So we're scientists, entrepreneurs, and company leaders. This diagram, I don't expect you to read it, but I thought it was an excellent portrayal of the impacts of climate change on human health, because it shows not only a direct effect, but the indirect effects, the secondary effect, the tertiary effects, the long-term effects. That bottom row, funny enough, you can't read it, they're all health bubbles. They are not talking about just the ecology and biodiversity, they're talking about the impact on our health. And this is, by the way, by an Italian visual artist, so I thought it was great. She's from Turin. And lest you think that's just a theoretical framework, let me show you some headlines that I just tried to put together over the last month or so. And I couldn't even keep up. I had to actually edit the slide yesterday because the CDC announced that there's an outbreak of Mpox. And this is happening today. This is not a theoretical future set of consequences and dominoes that are going to fall. They're falling now. They're falling now. And these are direct or indirect long-term consequences of climate change impacting human migration, human density, the zoonotic transmission of viruses and infectious disease, impacts on our lungs, impacts on cancer, et cetera, et cetera, et cetera. But we don't necessarily see it because it's so diffuse. This is essentially a clinical trial that we've been running on ourselves for about 300 years. It's a clinical trial. For millions of years, we've been living in a different context, in a different environment, and now, over 300 years, we decided to run a clinical trial on ourselves. Any government, any company that had tried to do that would be arrested, would be put in front of tribunals for trying to do a clinical trial with poisons on millions of people. So just keep that in mind, and I do agree, of course, that the climate crisis is a health crisis. But the issue is that we don't always have the tools to respond to this or to anticipate it. The traditional drug discovery paradigm is insufficient to go after this. I'll give you a few statistics. It takes about 10 to 12 years to develop a new medicine. Imagine waiting 10 to 12 years to respond to an emerging threat. You can't survive. That's not going to lead to resilience. It costs more than $2 billion to develop a medicine. Again, untenable. It's just not economical. And 2 billion people globally don't have access to essential medicines. That's essential medicines. That doesn't even leave, that leaves aside all the other medicines that these people need. It's actually more than 2 billion people that don't have access to medicine. So we need a new paradigm for drug discovery. We need a new paradigm for therapeutics. And here are some of the old technologies we've been using. We're using a 90-year-old technology to create vaccines. It's been wonderful. It's done in eggs. It's done in one egg, and then it's done in many, many eggs. And it takes months and months and months to develop the vaccine. So we learn of a virus, we learn of a few viruses, and my colleagues from WHO know this better than I do. And it takes us 9 months to get to those vaccines. And those vaccines, by the time they're done, have changed. The virus has changed. And we tolerate a 40%, maybe 60% efficacy, depending on the year. The way we discover small molecules is on the left. You see that funnel? It represents putting millions and millions of small molecules on an assay in an experiment to see which one works. That is the equivalent of throwing spaghetti on the wall, seeing which strand sticks, and then taking the last strand that sticks on the wall. It is the way it works today. And we use robots, we use armies of scientists to carry out that funnel. 10 to the 6 to 10 to the 9 experiments to get to an N of 1 drug. That's not tenable. And so on the right, what I'm going to propose is a paradigm of drug generation, drug creation, no longer using the word discovery in our thinking. Discovery, if you look at the formal definition, means to uncover by chance, to go search and uncover by chance, like some high-tech archaeological dig where we're sifting through sand and hoping to find a relic. Why do we discover drugs that way? We need to move to creation. And I'll show you that that's possible. We need to work on detecting things in the environment, determining the underlying mechanisms and molecular biology of what's happening, designing medicines, not discovering them, designing them at speed and scale to tackle the disease, and then deploying them. So 4Ds, I thought this would be pretty memorable, but we have the technologies and capabilities to do this. We have them today. And so this is not a message of dooms, this is a message of hope. So I promote that we can do this using programmable medicines. What are programmable medicines? These are derived from a direct understanding of disease and that can be designed and deployed deliberately, as opposed to using serendipity and chance and trial and error to find the medicines. And I'll give you 3 different examples as quickly as possible. I know we have to finish by 8, but I don't know if I'll make it. But to go in different degrees of abstraction to give you a sense for how this is possible. But I'll start with a very nerdy slide on biology. This is the central dogma of biology. In every cell of our body, every single cell, we have the blueprint for all our building blocks. That's in the nucleus, that's the DNA. That DNA gets converted to RNA, that RNA leaves the nucleus, and then it gets translated into proteins. We now understand this program. We understand this program very well, and we can take advantage of it. But there are more and more programs in biology. There's a program inside the cell. There are programs across cells, among cells. We are only beginning to understand these programs, and they are so complex, humans can't just remember them. I had to remember these for final exams. I don't remember them anymore. A computer is needed, and data is needed to train algorithms so that they can use this information to help us make better drugs. Drugs that are more likely to work on the first try, and drugs that are safer. So we'll start with DNA and RNA as medicines themselves. These take advantage of the basic program. Because you have the DNA code, you can make the protein of interest. And Moderna for vaccines was exactly that. We took the mRNA and we put it inside cells. Once you can do that, you have the code to make virtually any building block in the human body, any building block. Membrane proteins, secreted proteins, proteins inside the cell. And what we used it for was to take advantage of the immune program. We put the mRNA into the cell and created the SARS-CoV-2 spike protein inside the body, and that elicited the immune program that was triggered off. Now, we were able to do this in less than 48 hours. The minute we read the biology out in the environment and we had the sequence, we were able to make the first prototype in-house. That is unprecedented in the field of human history. And we were able to deploy this. Now, we'll talk about the challenges of now getting that to the real world. Let's talk about proteins. Proteins are the building blocks of life. Pharmaceutical companies have harnessed proteins in the form of antibodies. These are natural, usually molecules that help protect us inside our immune system. But we've now turned those into medicines. But discovering them again takes billions of trials, many, many months of optimization. And it's a pretty dumb process relying on trial and error. So what we've done, we've created a company called Generate Biomedicines that leverages AI and very similar to large language models that can take reams and reams of data and convert one language to another. We've done that exact same thing with the language of DNA to protein. So imagine feeding a computer millions and millions of protein sequences and structures on the right side, and also the corresponding code to make those proteins. So now a computer knows the language of going from DNA to protein structure and function. It can now reverse that language. It can now generate the drug of interest by giving it a prompt. So it's very analogous to how the large language models work to go from English to Italian or back, or to create a paragraph out of a prompt. So with this, we've been able to shrink the paradigm of drug discovery for antibodies from 30 to 42 months down to 8 to 12 months, and this is only getting faster and faster and faster. And we've applied it not only to the top 50 drugs in the industry, but we've applied it to a portion of the SARS-CoV-2 spike protein that is common to all COVID variants. So this one antibody can provide protection against a range of variants with a high degree of efficacy. These are the kinds of things we need to develop responsive, programmable medicine. And I'll stop with small molecules. And you might say, well, why are we going through all of these in order? The two drugs that I showed you up front are expensive to make, they're expensive to transport, they're expensive to take, but small molecules are the complete opposite. Easy to make, easy to transport, easy to take. And that's what's required for accessibility. That's what's required for global access. Those prior drugs, although the vaccine proved the opposite with the mRNA, antibodies cost $100,000 a year, $50,000 a year, tens of thousands of dollars a year for rich people to take. But they can't serve sub-Saharan Africa. Small molecules can. We've devised a computational system to understand biology, column 1, decode it, and understand the multidimensional changes that are undergoing within health to disease. Then have a computer tell us what are the small molecules most likely to reverse these changes. Which ones are most likely? This is not a human doing it, it's a computer doing it. And then the computer suggests small molecules that are likely to work, and then we try them, and then we try to understand it. So I'll give you one example with chronic obstructive pulmonary disease. On the left, you have a state of health. On the right, or in the middle, you have a state of disease. Chronic obstructive pulmonary disease has no cure. Once you've got it, you're in pretty bad shape. The picture on the bottom shows you what we see by the human eye. Healthy cells on the bottom on the left. They look good. On the right, you have cells that have overgrown. They're producing mucus. These are cells that have resulted from having multiple insults and getting inflamed. They're producing tons of mucus. This is called goblet cell hyperplasia. We can see it on the microscope. That doesn't tell us what to do. It doesn't inform us as to what molecules to provide. But if we encode all of the molecular biology underpinning the health to disease transitions, we can create maps like the ones above. These digital maps are fed to a computer and a network emerges. What are the multidimensional changes that are happening? Not one target, not one protein gone awry. What are the multidimensional changes that are going on? And then, next step, tell us which molecules are likely to drive that multidimensional change. And voila, we have 3 different medicines that the computer proposed, and all 3 of them, as you can see on the right, change the map and reduce the goblet cell hyperplasia. These molecules have never been used for chronic obstructive pulmonary disease. They weren't picked by a human, they were picked by a computer. And now we can use the similarities and differences to design better and better medicines much more quickly. And this is going to be a paradigm-shifting way of designing and discovering drugs. So, programmable medicines are coming, they're here. We have the technologies to start using biology, detecting biology, decoding the molecular changes, and using that to generate drugs as opposed to discover them. But we need to deploy these things. That's just the first part, the discovery and the science, as we discussed. But note here, the timeline it took to get the vaccine to the world, or to get vaccines to the world on the top, it takes 73 months normally. This is not to scale. These two graphs are not to scale. 73 months normally, but with Operation Warp Speed, we proved to ourselves that we can compress the timeline. These timelines are not the drug discovery timeline. These are the timelines for clinical trials, for manufacturing, for deployment and delivery. We've proved to ourselves that we can compress that, but it took scientists, corporations, small companies, big companies, manufacturing companies, government, the Department of Defense, global organizations to collaborate, to align, to speak different languages to compress these timelines. Let's not forget this, because once the threat is over, we usually go back to our old ways. We go back to 73 months. And I will posit that this was a health response. Similar things should be happening in the climate response. Thank you.